Good morning, everyone. We would like to welcome our distinguished guests and all those who are following this conference on clinical academic centers in Europe, challenges and opportunities online. This session takes place under the scope of the Portuguese presidency of the European Union and has the support of the Ministry of Science, Technology and Higher Education. The event was co-organized by the Portuguese Agency for Clinical Research and Biomedical Innovation, the Beiras Clinical Academic Center, and the Faculty of Health Sciences of the University of Beira Interior. The program includes two roundtables. The first one is dedicated to leveraging clinical academic centers in Europe, and the second one is focused on the establishment of partnerships and networking between clinical academic centers. Next, there will be a conference on networking and reflection on the possibility of creating an association in Europe for these structures. Each roundtable will be followed by a discussion and questions to which the people present in the auditorium will be able to contribute, and also those who are watching remotely through the chat on YouTube. For security reasons, people in the auditorium will have to use the microphone on the left of the audience. We will start the conference with the opening session that counts with the participation of António Fidalgo, Rector of UBI, Miguel Castelo Branco, President of the Directory Board of AICIB, Clinical Academic Center of Beiras, and Manuel Heitor, Portuguese Minister of Science, Technology and Higher Education.
University and this Faculty of Health Sciences probably are the most interesting interventions of the central government in Portugal in favor of the interior, and I think in that sense our health sciences faculty is a service you do to all the people that live here on the border with in the border with Spain. So have a nice day, a good work. Thank you very much.
Good morning. I would like to welcome you here, for those who are really here and for those who are here using the internet. We are with a great expectation regarding this meeting. But first, I would like to give some thanks. I would like to thank Professor Catarina Rezende Oliveira and AICIB, because we have co-shared this organization for this meeting. Of course, I would like to thank the presence of the Minister of Technology, Science and Higher Education, Sir Manuel Heitor, and also for the help and support of the rectorship and the University of Beira Interior. Of course, to the President of the Conselho Nacional de Centros Académicos Clínicos, and to the directors of the universities, faculties, and polytechnic institutes, and also hospitals that are present here, and for those who are at distance. Well, when a decision has been made regarding the 2 sessions on the academical centers, the one that occurred in Algarve and this one, a decision was made also that one of them was to be focused on research, and that was the one on Algarve, and this one will be centered on 2 topics. The topics of organization of academical centers, and the topic of what is the role of academical clinical centers in the health environment of the regions where the academical clinical centers are set. And so we have looked who will be the people that could talk about that, and we have come to a panel of people from several countries, from Europe and also from the United States, that have experiences in academical clinical centers and can share with us some of his ideas and some of the developments that have been made along the years. So we are with great expectation for this meeting, and we hope that this meeting can give us some new ideas, because academical clinical centers in Portugal are a new solution. We have not many years since they have been installed, and so we are in the process of building. And the process of building can be helped with these kind of meetings. We should think that this is very important for the development of academical clinical centers in Portugal. So, looking forward to the ideas that are going to be shared in this meeting. I hope you have a good day and an important one for these ideas. Let me give you some housekeeping informations. This event was evaluated by the health authorities. One of the things that they give us information that is mandatory is to have the information of the people that are present here. So I'm sorry for the fact that you have to register at the entrance of the auditorium. And the coffee breaks are also changed in the solution, COVID solution. That means that who wants to have some coffee or some fruit or some biscuits should go outdoor of the auditorium. There is a machine there, and there is some cookies and some fruits that you can have, but there is no organized break and not even support for that break. Then, for those who are going to have lunch with us, you are of course very welcome. But there are some organization issues also there, but everything is in agreement with what the health authority gave us as instructions to be done. So you can be sure that everything is for your own security, and everything is taken care. Have a nice day. Of course, if you need anything else, please contact me, and of course we'll be glad to help you. Thank you.
Penso que podemos tirar aqui a máscara. Muito bom dia a todas e a todos, e sobretudo para agradecer ao UBI a organização deste evento e, obviamente, reconhecer o trabalho do professor António Fidalgo e dar os votos ao futuro reitor eleito. Let me turn to English. I believe this conference should be an international conference with speakers from different parts of the world, and I would like certainly to acknowledge first and foremost the importance of the topic of clinical and academic centers and the issue why during this semester, following the decisions taken with the so-called trio of the presidencies of the European Union with Germany and Slovenia, we gave a special emphasis to clinical research and in particular to the collaborative type of institutional partnerships which are required throughout Europe to make clinical research a reality. And in this context, we all know the importance of clinical academic centers. Let me recognize also here the Portuguese Agency for Clinical Research and Biomedical Innovation, AICIB, and Catarina Rezende Oliveira, the presidents, as well as the National Council of Clinical Academic Centers, represented here by Manuel Sobrinho Simões. We have also within us a new clinical academic center, and Artur Silva from the University of Aveiro represents, and we hope that this process is not just an enlargement, but also an improvement of quality, of exchange of quality, and above all, the ambition to have clinical research throughout the university and clinical care system. During this semester, we have organized two major events in the health sector, one in Porto, about cancer research, and the Porto Cancer Research Declaration is become very critical in the context of what will be in the coming years the challenge for Europe in general to promote cancer research with a specific target to make sure that by 2030, 75% of those which have diagnosis with cancer can have a long time survival, and by long time the expectancy is at least 10 years, and that we know will be particularly critical to build a network of research infrastructures. The discussion in the Porto conference was focused on three types of infrastructures, which gave rise to the so-called Porto Declaration on Cancer Research, which are particularly associated again with infrastructures for clinical international research, second, infrastructures for clinical trials, third, and last but not least, infrastructures for outcome research, particularly in collaboration with epidemiologists. It was also clear the critical importance during that conference and the preparation of the conference over the last months of the key role of new forms of pathology, including digital pathology, but overall the digitalization of the clinical process, particularly associated with oncology. We have also organized the second conference in Coimbra with the European Molecular Biology Lab, particularly focused on infectious diseases. And again, the role of clinical research, the interface between basic and translational research and the healthcare needs were emphasized throughout that conference, very much focused on the issues associated with infectious diseases and the key role of the articulation between the most fundamental basic research and the entrepreneurial capacity to do disruptions in the market, particularly associated with the production of vaccines, among other therapies. These two major so-called high-level events organized during the Portuguese presidency followed the December event organized in Germany in last November, and will be followed by one high-level event in the Slovenia presidency. In addition, we have organized 2 further events, one in Algarve, and today these events on clinical academic centers. And it is important that this row of events does not happen by accident, has been planned in order to emphasize the key role of the need to foster and promote in Europe a better cooperation between those associated with clinical practice, with clinical education and medical research through a continuum of activities which certainly are particularly critical to improve health conditions and the lifestyle conditions in Europe in the coming years. It is also clear that we have launched last February the Horizon Europe program with a unique package of funding lines also for clinical international research, including a mission, the very first mission on cancer for Europe, as well as a large-scale partnership on mental diseases. But overall, this issue, again, has become and has been planned over the last 2 years, but now is more urgent than ever because of the unprecedented times we live in Portugal, in Europe, and worldwide associated with the pandemic crisis. And I believe that in this type of events and in the process which we will face for the coming years, this will be particularly critical to take lessons out of the last year, and particularly to guarantee that we strengthen ourselves to prevent further pandemic crisis, because overall scientific evidence more and more shows that we are facing what the United Nations Development Programme have called a new geological area, the Anthropocene, particularly associated with issues which represent forms of climate change, but overall the domination of human and social activities on the planet Earth. But I would like essentially here to consider at least 5 lessons learned out of the last year, which in my view are particularly critical for the development of clinical academic centers. First, when we look at the way we could over this time to stress time in terms of the development of vaccines, and in fact we have vaccines spread over the world, we clearly have understood that the new vaccines, particularly those associated with RMNA, have been produced in places which were able to articulate fundamental research and strengthen fundamental research with disruptive startups and companies. The case of BioNTech in Germany, particularly developed over the last 20 years with the European Research Council type of funding, together with a disruptive company, or the case of Moderna in the United States, heavily funded through the NIH, and then supported with the venture funds in Boston associated with MIT. So this idea, more and more, of the needs to foster new knowledge through basic and fundamental science in close articulation with new elements of innovation systems, particularly associated with disruptive companies and groups which are able to speed up the process of knowledge transfer, is not new, but has become more and more critical. And therefore, again, the continuum of activities from basic research to entrepreneurial activities are central to the clinical academic centers and will be central in the years to come, and therefore on this conference. Second, we have also understood that we need to learn more and to train more our population, certainly in medical education, in a wide variety of topics, but also at large in a broad set of activities from nursery, health technologies, and social support to the elderly, but also to the population at general. We should be proud in Europe that last year we have attained the target of 40% of the overall European population aged 30-34 years old with a university degree, but we need to do more in Europe at large. Actually, in Portugal, we have also got that target, but we know that we need to expand, further expand higher education and the penetration of higher education, and this can only be done with a strong diversification of the institutional setup, but also a different set of the supply of higher education, combining the traditional long-term education with other forms of education, particularly short-term initial training, but also post-grad training for reskilling and upskilling of the population at large. The third lesson, I believe, has become clear in Europe is the regulatory framework. We definitely understood that the diffusion of vaccines in Europe has become slower than in other parts of the world, but also the penetration of innovations, particularly in the biomedical area, has become particularly difficult and complex following the current regulatory framework. We can speak and give examples from ventilators to the most diversified set of biomedical dispositives and diagnostics or therapeutics, which has become, I will say, a nightmare to penetrate into the market. Certainly, we need to do this with special care, not only in terms of, say, ethics of the process, but to make sure the necessary safety conditions in the health system. But we also understand that the current European and in many national member states regulatory framework has become an obstacle to the promotion of innovations. In association with this, but in a broader context, I believe the fourth main lesson that I would like to take, which is also critical to the clinical academic centers and was particularly discussed actually in the Porto Conference on Cancer Research, was and is the process of digital transformation. Certainly, the medical area at large and public health system will benefit definitely from an increasing, say, digitalization of our society and economy, and what we consider to be the digital transition and the massification of those of the digital means. But we understood, particularly in some zones of Europe, how difficult it has become to use these areas, particularly in public health. A clear example is contact tracing. We have been able, through leading centers in research, actually research funded through the European Framework Programme over the last 15 years, in Europe was possible to build a contact tracing applications with interoperability throughout Europe. And this is associated with many engineering system centers, including in Portugal and many other countries. And it is interesting to note that in some countries and in some regions it worked, and in other regions it did not work. In Portugal, for example, the so-called Stay Away COVID application has become a nightmare to penetrate into the system. The exact same application in some zones of Germany or in Switzerland worked very well, but it did not work in Portugal, in Spain, in Italy, in some countries. And therefore, the context of digital transition is particularly conditioned and dependent on the socio and institutional context, particularly of the health system, but also of those acting, including medical doctors. And therefore, it is not enough for us to consider digital transition per se. but the social and institutional context of digital transition, particularly in a context of public health, will be particularly important. And this, again, will be critical in schools of medicine, in schools of nursery, in overall health institutions, to better provide the institutional and social context for the digitalization of our societies. The fifth lessons I believe we need to take is about open access to data. Again, this was a topic particularly emphasized in the Porto Conference on Cancer Research, but also in the Coimbra Conference on Infectious Diseases, the need more and more to foster access in an open way to data, particularly to public data. But again, we need to face a lot of regulatory institutional obstacles, some of them associated with data protection, individual data protection, which we certainly need to be particularly careful, but other particularly associated, and those are should be easier to disrupt, associated with institutional barriers, which do not facilitate the transfer and development of open platforms for data access. Next week, we will have another conference organized by Commissioner Maria Gabriel with the launching of a major funding platform to open up data platforms, particularly in the biomedical area and in particular to health system. Again, the role of clinical academic centers in this area of facilitating, providing, stimulating platforms for open access of data, particularly in biomedical terms, are particularly critical. In the Portuguese case, we have experienced a few very interesting pilot projects, from cancer tumor to the dermatology type of data, to also projects in the area to prevent, in the area of antibiotics, to provide antibiotics. But in all those projects which are going on, it is clear the institutional barriers that have make very difficult the access and the interoperability of data. So these are, I'm sure, a few of the lessons we can take out of the last year, which puts, in my view, a clear need to strengthen clinical academic centers, among many other issues which are in the continuum between the clinical care units, basic and fundamental research associated certainly with medical, biomedical education. And again, the role of clinical academic centers are central to all these issues, which go from scientific issues to essentially public health issues. And again, I thank you, all of those associated into this process. Today we will listen about Portuguese experiences, but also those throughout Europe, in Leiden, in La Sapienza in Italy, in Lille in France, and we have also with us colleagues from Eastern Virginia in the United States. Certainly, by exchanging ideas, by crossing collaboration, we can also learn about different institutional barriers, but also different institutional facilitators about the implementation of clinical academic centers. And it is clear that throughout Europe, we have a quite diversified system in North, Central, Eastern and Western Europe, some cases which work better, others which are more difficult. Each case is in own case, but again, institutional issues, economic issues associated with incentives of those working in the biomedical sector, in particular physicians, do provide a complex institutional and individual setup, which we need to more and more to face, again, together with the overall idea to improve the health system in a knowledge-driven society. So I thank you all for participating, and I particularly thank all of those associated with the several sessions, and we look forward to improve more and more clinical academic centers and clinical international research throughout Europe, not only in the cancer or infection diseases area, but horizontal to all areas of clinical care. Thank you very much.
We will now proceed to the first roundtable on the topic of leveraging clinical academic centers in Europe. This roundtable will be moderated by Catarina Oliveira, President of AICIB, Portuguese Agency for Clinical Research and Biomedical Innovation.
This morning session. So good morning, everyone. First of all, I'd like to welcome all of you to the first roundtable of the meeting, which will be focused in the leveraging of clinical academic centers in Europe. Just before starting, I would like to thank the invited speakers in this roundtable for having accepted to participate in the session. The session is aligned according to the agenda, and we will start with the presentations by the invited speakers, and then we will have a final discussion after the 4 presentations. I'd like to ask all speakers, please keep the time, 25 minutes maximum for each talk, so that we can have time for discussion. I'd like also to ask the audience present in the room and also the audience at distance to use the chat in YouTube to address the questions for each speaker, which will be answered in the final discussion. So it is my great pleasure to introduce the first speaker, Professor Pancras Ogendorn, who is a professor of pathology, vice chair of the board of directors and dean of the Leiden University Medical Center. Apart from that, he is guest professor at Oxford University and the Free University of Brussels. His talk is entitled Opportunities and Threats to Clinical Academic Centers in an Age of Uncertainty. Professor Pancras Ogendorn, please, the stage is yours.
Well, thank you very much for the kind introduction, and I hope that all the electronics will work in the way we try to organize this leveraging clinical. What I would say, of course, is certain, but also a reason for a chance. And I hope, yes, everything already, so I can skip this slide. So I like to show a little bit of my vision by the development of academia in Europe. Start with this one of my favorite slides, where you can see the map. In that, these are depicted. In your country, you already presidents. And in the Netherlands, we were in swamps, universities. And what evolved over 1500s, which comes from the European Space Agency, you can see where the light is, where currently the highest economical activity is. And what I would try to say in the coming 25 minutes is that economic activity is hand in hand with scientific activity. And you can see here, of course, London, the Oxford and Cambridge area, but also Portugal still present, Madrid, clearly visible, and Barcelona and Northern Italy. And we are always very happy that there is a bright light in the Netherlands and Belgium as well. And when you look this to a global view, also from the same space agency, you can see what's going on in Europe. Europe quite intensely light up. Of course, the United States on the coastal areas, but this gives also the responsibility, but also that we are conquering each other in Europe in a high way as a result of economic activity and scientific activity. And the only way we can survive is to enhance innovation and connect to the right institutes throughout Europe. So what I would like to do is to discuss with you a number of things: challenges and dynamics of strategic planning of academic medical centers, international level, on the health agendas, to transport that to the national level, creating societal outreach, so important also to get the society involved in what we are doing, because in the end they are paying it, and to create what I will stress is scientific stability, that researchers and knowledge institutes know how they can get the money, how they are evaluated, and not are the result of ever-changing evaluation schemes and funding schemes. I think that's stability is very, very important for the years to come. Current challenges, of course, the innovation pipeline already mentioned with regard to infectious diseases. What is cutting-edge knowledge? How do we engineer the workforce of the future by blended learning? We learned a lot of that in the pandemic, but I think that's the way to go. And the importance to train ambassadors for health centers, talent and teamwork in the organizations, but also in between organizations. And in the end, we have some time for a dialogue. So we have to realize that academic health centers are an unusual biotope. I'm very happy to hear that Portugal is taking steps to create them, but that's certainly not the case throughout Europe on all places. And in such an academic health center, there are not 2 but 3 DNA strands attached in one body. That's patient care, research, and academia, which is an essential getting together in one organization. And of course, academic health centers are research intensive and customer focused. And what are our customers? It's important to realize that's both the patient as well as the student we are educating in the end to perform research and medical care. So a customer focused approach, I think it's important. And all in all, it's about humans. We are treating human beings, but we are doing this with humans. So when you want to manage your center, you have to manage the humans in it. Given constraints, financially, for instance, you have to know that there is always a strong internal competition, which means that you have to manage that in a very careful way. Either you want to have people competing internally, but it has to be clear what are the goals and what are the ways to reach these goals. And that's an important thing also in Europe, in a political perspective, that should not change every, let's say, 3 or 4 years, but the stability there, I think, is very important. And of course, and already the chairman alluded to it, it's important to have state-of-the-art infrastructure, not all the infrastructure in the same places, but use them together to build a strong network of infrastructures within one country or a number of countries in order to use each other infrastructure in a optimal way. And again, we have to be able to have stakeholder network management and try to have as few fluctuation in external environment as possible. And I think that's for Portugal, but also for Europe, and certainly also for the Netherlands, an important thing, step to go in the coming years to create that national stability in funding, in strategy, and in network formation. So, having said that, then strategic planning is an absolute precondition to overcome these challenges for university medical centers, but also the universities involved, and of course the other hospitals around us. And they all need to be aligned in policy making, so it's useless to make policy in one university medical center and not in a national or an international scheme. It has to be locally but strategically aligned at the national and in the international level. And of course, this needs to be execution oriented, so try to focus on teams and to be agile, not only be very theoretical. And we have seen, of course, that with the pandemic as well, the very, very quick shift towards research in infectious diseases. So here I listed quite a number of things which are coming to us as academic medical centers. And I think I made this slide for my own organization, but I think it's for every medical center throughout Europe. We are now encountering various populations as opposed to previous years. There are demands for reference and relevance for society. When we can't explain it to the civilians in our countries, we are not getting the money we need to do, etc., etc. As you can see here, collaborating networks, and you can see all the important issues I've listed here, which I think is of relevance for all the university medical centers throughout Europe. And when you want to organize this, it's very important, in my view, to think outside in. What are the civilians in your country thinking about your medical centers? It's very, very important, because otherwise you will never be able to implement a strategy and a funding strategy as well. So the focus would also needs to be for a societal outreach, to involve society in what we are doing, and not just drafting what we are doing for ourselves, and connect to national programs, and very importantly also to European programs, and to talk to the external stakeholders. So important, again, to create stability that we know what we are doing, where we are investing, and how we are doing this. And I think that's one of the things, the most important things I learned for success, is to create a stable view, that your researchers and clinicians know where to go and how to get their funding arranged, and invest and commit in people again. People are your most important things. The best faculty, the best doctors, the best students and staff, and go away from hierarchy, just look for talent. And most of the time they are in young people and not on any very old ones. So take your time to identify talents as well. So three important things: think outside in. So public value, create public value. Be aware of the fact that you have to create this public value in order to come to public funds. Very important. And the third one I could say is look for toppers and talents. So invest in people. This public value is, of course, to connect and create agendas for innovation. And we all know, of course, the Sustainable Development Goals, the current program on Horizon 2020, but Horizon Europe coming. I think making a connection between academic medical centers and these international programs, I think it's vital for success. You can be inspired. The good news is that all these things to think about are also relevant for countries like the UK, but also for the Netherlands. So there's quite some literature around in the world, so you don't have to invent the wheel yourself. And I just mentioned here 2 books of Richard Barker, which inspired me a lot to think about the future of medicine and bioscience in the future, which can, at least it helped me to draft the structure we are working here in Leiden. Get also inspiration by inspirational leaders. Here an example, invite them to your place in order to be connected to the international community, I think very, very vital. And then build up a case. The case from the Netherlands and Dutch national research agenda, I think, is very important. So not a local agenda, but a national agenda. Translate that into a research agenda for what we call here sustainable health, and also pick up a number of themes which are so important for Europe currently, like the open science surrounding. When you want to be seen as a research institute, you have to show your data. So open science strategy is very important, not only digitalization, but also be open to the world. Health fund and patients, very important. When we are not working together with our patients, and especially for rare diseases, I think we are not sustainable in the end, and the public will not see us as their partners, but see us as the consumers of their tax money. So engage with patients and funding organizations, as you can see here, and cooperate with MedTech. And the bottom line, what I try to explain in the Netherlands, it's the economy stupid. When we are good in making good academic health centers, of course we are able to deliver service to the population, but also to deliver service to the economy. I think it's vital to build around academic health centers, and I will come to that in a minute, a park with companies where we can work together to make from ideas a product which we can bring in the end to a patient. So, and cooperate with your local municipality, for instance, for lifestyle projects, but also for economic affairs by creating industry around health care centers. Very, very important. So the core tasks, as I said, are the 3 combined. So when we have research, of course, combination with valorization activities like what we have in Leiden, the Bioscience Park, in order to make products, to bring that to the patient. That's the other important thing I would like to stress. Collaborate with industry, with the medical industry. Very important to be sustainable in the end. And as you can see here, it's here in Leiden, all under one roof. Basic research, translational research, clinical research, and patient care, education and top specialist care, but also this valorization activity together with industry. And we do that together with students, new bright brains, together with professors who think they know how things are going. But this connectivity between the academic community and the students, I think that's very, very important. You should not separate them apart. So create a connecting curriculum and also be very sure that you're educating your youth in order to have them available to implement the new findings which you discover in research. So I'll skip this one. So important is to have the strategic goals we discussed a little bit, but the creative ideas of the professionals. And when you are successful in combining them, I think then you can you can achieve your goals, the relationships between autonomous expertise of professionals and the strategic objectives of the organization, which leads to a pipeline in academic medical centers from groundbreaking research to translational research to preclinical research and innovation at the bedside, and then a regional application to the non-academic medical centers. And this slide I've just put in because in between there are a number of other partners you need as academic medical centers. I already touched upon the importance of industry. I think it's vital to make products in order to bring them to the patient. And in the introduction it was said the vaccine strategies. It might be good to know, so Janssen, which is here in Leiden, produces massive amount for the whole world, the vaccines here. It was based on a patent and invention of 30 years ago here in Leiden University Medical Center, and now we can serve the world by this industry partner with the vaccines. And next door, the AstraZeneca vaccine, for instance, is also produced in Leiden. You can't do it as an academic health center, but you can deliver the knowledge and the patents and the inventions to the industry and bring that back to society. As you can see over here, we have to close this gap. So from my side, an important plea to involve industry in your strategy. You need industry in order to close the gap in manufacturing and innovation. So here you see the Bioscience Park in Leiden, about 160 companies now. Cutting-edge research is the filament for innovation, so you have to think about state-of-the-art research infrastructure. Without infrastructure nowadays, you can't do anything in medical research. So that needs to be in a planning agenda of the country as well, where to put which type of industry. You don't need all the infrastructure in the same place. You can divide it a little bit throughout the academic medical centers, but then you have to organize that it's available for everybody in the country, like we did in the Netherlands. It will attract research, very important, but also research talent. And I think infrastructure, our experience is when you have high-end infrastructure, it attracts talent from all over Europe, people wanting to work at your place because you have certain infrastructure available, which is not available at other places. And of course, you have to create sustainable research groups. And again, their stability and funding schemes in the country is very, very important in order to have multi-year earning power and not every year another goal. And of course, you can do that throughout Europe. You need to do that by external collaboration as well. So example of good stories here, two of the research groups. You see on the left-hand side a young researcher working on malaria in the middle of fundamental research, publishing in Nature and Science. And on the right-hand side, a clinician. So you need to train clinician science in order to have the dialogue, like you see in the right picture, two famous professors from Leiden on the left side, a pharmacist on the right side, one of the most honored scientists of Europe, with multiple ERC advanced grants, etc., a chemist, and the interaction between these both worlds, I think that's vital to get cutting-edge research running. Interdisciplinary, very important. So when you want to have an academic medical center of importance, you have to do interdisciplinary research, not just disciplinary research, and create fellowships to stimulate this internal cooperation and to attract international talent. I have to say to you, one of our best associate professors is coming from Portugal, and we are very, very happy with him. And we were able to attract him because of infrastructure and a sustainable funding scheme, and create MD, PhD programs in order to maintain research talent. So given the time constraints, I think I'll leave it over here already touched upon in the introduction the importance of data science. I think when we want to create world cutting edge academic medical centers, we need to combine education, patient care, and research under one roof to develop a national strategy for that, to make a bridge with the European strategy, and very importantly, set long-term goals in order to create a stable environment. And I think, by the sake of time, I leave it here and I give the floor back to the chairman.
Thank you very much for the very inspiring talk. And we are now moving to the second topic to be addressed, which is the role of clinical academic centers in improving health. And to present and discuss this topic, we have the privilege to have with us Professor Eugenio Gaudio. Professor Gaudio was former rector of Sapienza University in Italy, and he is since 2020 counselor for the Ministry of University and Research for the Health Education field and relationships with the National Health Service. Professor Gaudio is the International President 2022 of the M8 Alliance. Please, Professor Gaudio, can you start?
Yes. Good morning, everybody. And first of all, I wish to thank Professor Miguel Castelo Blanco, President of the Directory Board of Clinical Academic Centers, and Professor Catarina Resende Oliveira, President of the Agency of Clinical Investigation and Biomedical Innovation, for their so kind invitation to participate to this very important meeting. I want to apologize if at the end of my presentation I have to leave this meeting for another engagement with the Italian Minister of the Higher Education and Research. And if we want to talk about teaching hospitals, first of all, we need a definition of teaching hospital. According to an interesting book that was published in the US at the beginning of this century, a teaching hospital is a major healthcare organization committed to the principles of academic medicine that offer patient observation, diagnosis, and treatment through a variety of distribution channels. It is important to examine closely the 5 key words in this definition. Major. Teaching facilities are usually among the largest, most sophisticated hospitals in the predominantly urban markets they serve. Healthcare. Above all, teaching hospitals provide healthcare services to patient population. Organization. Teaching hospitals bring together a variety of professionals and to mutually cooperate and achieve common objectives. Academic medicine. Teaching hospitals are committed to the principles of higher education. Distribution channels. The distribution channels of healthcare should vary, including both inpatient settings and outpatient clinics. Teaching hospitals are very complex organizations because they have multiple objectives They provide health care. They train physicians and other healthcare professionals. They contribute advances knowledge, research activities, and in addition, they should achieve satisfactory economics. From here, there is the concept of loyalty delusion, because, for example, a physician at a teaching hospital usually has a dual position, as both a faculty member in the university and as an attending physician in the hospital. Finally, according to this book, teaching hospitals are facing a highly unpredictable and uncertain future. The unstable healthcare industry, which allowed teaching hospitals to practice academic medicine in a financially secure environment, has been replaced by an extremely turbulent and competitive marketplace. This is true in the US, but also in Italy, as well in all other European countries. There is a big debate about the quality of care delivered by teaching hospitals. According to these two articles, the quality of care delivered by teaching hospitals is higher compared to non-teaching hospitals. For example, the second article found that for approximately 21 million hospitalizations in Medicare hospitals in the US, adjusted the 30-day mortality rates were significantly lower at 250 major teaching hospitals compared with about 900 minor teaching and more than 3,000 non-teaching hospitals overall. But the problem is a little bit more complicated. By contrast, this systematic review found no differences of health outcomes between teaching and non-teaching hospitals, with large heterogeneity among the studies retrieved from the literature, but probably focusing only to health outcomes and quality of care delivered is not a good method to analyze the value of teaching hospitals. Using the words on the author of the meta-analysis, John Ioannidis, teaching in healthcare setting does not affect only patients and only in the immediate term. It is an integral part of medicine with benefits to patients in the long term as well. As such, teaching should be fostered to create better practitioners in the future for both academic and non-academic centers. Another important debate is about the costs of teaching hospitals. Teaching hospitals where healthcare professionals are educated and trained are generally considered to be more expensive than non-teaching hospitals. This could be true in many situations, but not in all situations. For example, the first article is a cross-sectional study of more than 1.2 million hospitalizations in Medicare hospitals in the US, where major teaching hospitals and higher initial hospitalization costs than non-teaching hospitals, but the total costs of care at 30 days were lower at major teaching hospitals, largely because of lower costs for post-acute care services and readmissions. The second article showed that training postgraduate programs for medical residents may have positive financial impacts on teaching hospitals. As a consequence of the COVID-19 pandemic, all of us are strongly convinced that the healthcare system in all countries of the world need to be reformed. Medical teaching facilities should be leaders in this reform. The authors of this article, published on Lancet 10 years ago, believe that to transform healthcare, academic health science centers should evolve further into academic health science system. The term academic health science center connotes a specific location where patients receive care, for example, a medical campus, whereas academic health science systems are thought to be an integrated healthcare delivery system that not only include the traditional medical center, but also a network of community hospitals and practices. This is a way to reinforce primary health care outside the hospital, with a focus not only on the therapy of disease, but also on health promotion and prevention of disease, including infectious threats. Academic health centers will have a key role in improving health. Improvements in health could happen most readily when the clinical and the biomedical intersect, or when efficacy and effectiveness come together. An effective role for the academic health centers in the process of improving health would be to move the perspective of health at the population level, a focus that is important as the biomedical advances that garner so much attention. In this perspective, the work of academic health centers should be guided by three overarching focuses, as follows. The first, successful improvements in health occur when we move out of the lab into the community. When, in other words, we move from efficacy to effectiveness. We are rightly proud of our efforts within the walls of our laboratories and the general clinical research centers to find treatments that are efficacious in saving lives. But every day, physicians and medical students face consideration not addressed in controlled clinical research. The many patients with comorbidities who would have been excluded from the research altogether, patients who may not have insurance, and those who struggle to appropriately follow a medication regime. Therefore, it is needed a more explicit focus on translating our work from efficacy to effectiveness. The second point, health system today also focuses too much on acute care, despite ample evidence of the benefits of preventive care and of the ability of public health intervention to change health practice. Public health measures have had effects on clinical medicine in many areas, including maternity care, coronary heart disease, metabolic disease, and cancer. The third point, we need to take much more forceful action to address the profound health disparities that exist in our population. Differences in access to care and in outcomes by population characteristics are unacceptable and must be addressed systematically and urgently. In this scenario, some further issues need attention. The first one is the sources of funding, since making an important change would require adequate funding. However, each of the potential funding sources could be dwarfed by the normal budget assigned to healthcare. Those resources are directed at the care of individual patients, but are resources that are available for improving the health of the population. Another issue deals with leadership role. Academic health centers are in many respects the most conservative part of the healthcare system. Conservative in the sense that fundamental change is very difficult. A study on clinical quality improvement stated that substantial clinical change in orders of magnitude harder in academic centers than in private settings. Most major medical centers see the path to greatness as national excellence in biomedical research. However, academic health centers ought to strive for excellence through regional effectiveness as well, in other words, in how successful we are at improving the health of the population in the geographic area around us. To be the leaders in improving health at the population level, academic health centers will need to identify new kinds of research questions toward us. The studies by Schwenk and Green demonstrated the importance of deep involvement in system change both within and outside our institutions. Therefore, the neighbors are appropriate partners for academic health centers. Investing in these kinds of partnership activities also requires that we attract and retain faculty with a kind of expertise different from the kind that may be most familiar for us. For example, faculty should be responsive to being rewarded for improving the quality of the care they provide, without outcomes among the patients playing into questions of tenure and promotion. Other kinds of infrastructure will also be needed. New organizational units and processes within the academic health centers are necessary. For example, in a new approach, networking ability and computer services become increasingly critical. These potential new directions will require substantial investment, analogous to the investment that academic centers have made over the last generation in basic biomedical research. Some of the essential investment will be brick and mortar, but more will be in information technology and other soft links. In many settings, it's easier to get funding for new buildings and specific high-ticket equipment than to get large amounts of operational funding. Ultimately, we improve the population health, and to be leaders in the transformation of healthcare, we will have to push ourselves outside our comfort zone. Academic medicine must evolve dramatically. Academic health centers are organizations that pursue a tripartite mission. One, to provide high-quality care to patients. Two, undertake clinical and lab research. And three, train the next generation of health professionals. To deliver these missions, academic health centers employ a wide variety of governance and operational models in combining higher education institutions delivering health professional education with one or more affiliated or own teaching hospitals or health systems. Today, academic health centers are either established or developing in multiple countries and are well established in North America, where they are the focus of a substantial body of research, commentary, books, and policy reports. In the United States, academic health centers are known as powerful economic engines for their role in employing of thousands of people and for their generation of economic growth through research and innovation. In Canada, they are similarly seen as critical components and drivers of a sustainable, innovative health system, and as innovative organizations that deliver state-of-the-art care by structuring interdisciplinary healthcare teams around the three-part mission. In the United Kingdom and Australia, academic health centers are relatively new structures. In the UK, the establishment and national designation of various academic health centers models is focused on bridging research translation gaps through alignment of academic and clinical missions of universities and teaching hospitals. The establishment and designation of academic health centers models in Australia is similarly aimed at enhancing research translation with emphasis on addressing current issues relating to health system fragmentation. There has been long-standing interest in the role of academic health centers in addressing health system equity in the United States, where academic health centers have been known for their social contribution, such as caring for poor and unserved populations. Health equity is defined as the absence of avoidable and unfair inequalities in health and represents a core principles underpinning healthcare reform in many countries, and health equity concepts are also central to global commitments to achieve universal health coverage. Responding to the global spread of academic health center models and the growing interest in their role in addressing health system equity, several commentaries and studies examined the state of the evidence on the equity role of academic health centers. Most of the studies are based on the evaluation of academic health centers in the US, while some others examined this organization in other countries, and the major issue resides in how health equity is characterized and described in literature. 8 descriptive themes could be identified and would deserve a proper analysis. Population health. Multiple contribution in literature describe the health equity concept in relation to the population health role of academic health centers. Improving population health will highlight as a key focus of health reform in many countries and the key elements of framework for rethinking the way of academic health centers. A focus on population was contrasted with the traditional focus by academic health centers on the health of individual patients, as a fundamental disconnect was ascribed between the success of academic health centers as leaders in the provision of advanced care and specialist training and in protecting the overall health in the populace. In the UK and Canada, academic health centers were noted to have sought to emphasize population health through the creation of academic health science networks. To this regard, the effort of refocusing their activities towards population health would be encouraged in academic health centers. Addressing health disparities. Multiple studies describe academic health centers as having a particular capacity to lead health system initiatives aimed to addressing health disparities. Reasons for this assertion included the perceived capacity of academic health centers to interact with all points along a research translation continuum and their multi-professional and multidisciplinary composition and their position as centers of convergence for healthcare research and workforce training. The third, social determinants of health. Several papers underscore the role of academic health centers in addressing the social determinants of health, defined as the factors including social circumstances, environment, behavioral choices, and access to medical care that are able to determine or strongly influencing the ability to achieve and maintain good health throughout one's life. Community engagement was defined as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. Academic health centers need to strengthen links with communities in order to improve health outcomes with the localities. Partnership between academic centers and community organizations can develop and strengthen community capacity, address disparities in healthcare, and support the mission of the academic health centers. Another important topic is global health. Academic centers could have a potential role in global health, defined as a field of study, practice, and research that transcends borders, engages in multidisciplinary activity, and includes both population-based and clinical focus. Academic centers should create not only novel drugs, devices, and other technologies, but also new ways of deploying inexpensive preventive and treatment strategies among populations to contribute to addressing global challenges. Academic centers have the responsibility of addressing population health at not only local and national levels, but also global levels. The global health activities of the academic health centers were described as involving collaboration with partners in every country of the world, and very important for clinical and translational research, global healthcare management, and medical and health professional education. Multiple commentaries describe the financial unsustainability of the national health systems in many countries, highlighting the rising costs, increasing and affordable insurance coverage, and challenges in the delivery of quality, equitable and accountable healthcare, and the implication of this on academic health centers. Health equity was described as a primary goal of the Patient Protection and Affordable Care Act, which is designed to ensure that all people have access to quality, affordable health care. Value-based and accountable financing models are important for health equity concept that can be also described in relation to the shift observed in many healthcare systems from volume-based payment structures to value-based structure. This shift was described as a moving from a focus on caring for sickness to one concerned with wellness and patient-centered, coordinated models of care. Many papers sought to reconceptualize the traditional current role, mission, and value proposition of academic health centers, emphasizing the responsibility to improve health rather than health care, improving health rather than health care. Health centers have tended to become ends in themselves, potentially obscuring that what should be one overarching goal. Describe the values as improving value for patients, improving the health of the public, improved health and well-being, serving the health of the nation, and meeting the needs of patients and society. In general, the analysis of literature on academic centers using the health equity lens, which involved examining how academic centers are or are not eliminating unfair and unjust health disparities, and addressing the determinants of these health disparities has contributed a number of unique findings. The concept of health equity relation of the role of academic centers was expressed most obviously within the themes of addressing health disparities and the social determinants of health. These themes are central to the definition of health equity. The interest in health equity role of academic health centers, however, coincided with a substantial degree of uncertainty about the overarching role and relevance of academic health centers, and in particular confusion about their main missions. The role confusion revealed a degree of questioning about whether academic centers exist to serve their own measure of excellence, their patients, the communities in which they are located, their nations, the world, or a combination of these. This perceived lack of clarity about the overarching role of academic health centers may have particular relevance for any health equity focused objectives. Achieving clarity in aspiration and directions is understood to be particularly important in the case of health equity, which can often be subject to different interpretations with implication for prioritization and resourcing. In conclusion, I have substantial interest in the capacity and the potential of academic centers to adopt a health equity role is clear, highlighting the relevance of health equity concepts in discussion about the role and mission of academic health centers, particularly in the context of the growing global focus on health equity as a key measure of health system performance and the global spread of academic health center models. Policymakers involved in establishing, resourcing, and evaluating academic health centers models in multiple countries might consider the alignment of academic health centers' goals with those of the overall health system in which academic health centers are embedded and are being developed. In parallel, academic health center leaders might seek to understand the equity focus on their own organization, including whether health equity is or should be a goal, how equity concepts are reflected within their organization vision and mission statements, and whether any equity-focused activities are generating results. And thank you very much for your so kind attention.
So thank you very much, Professor Eugenio Gaudiu, for the very interesting talk. Just addressing the diversity of clinical academic centers throughout the world, and also focusing on the 8 major objectives of these centers and focus on global health and health equity that we hope to have the opportunity to discuss with you in the next future. So thank you very much, Professor. We are moving now to the next speaker in this roundtable, Professor Donald Combs, Vice President and Dean at the School of Health Professions, Eastern Virginia Medical School in the United States. Dr. Combs is active in Society for Simulation in Healthcare, the Association of Academic Health Centers, and in the national policy discussions addressing health workforce planning, applied information systems, and medical modeling and simulation. Please, Professor Combs, the stage is yours.
Thank you very much. I appreciate the opportunity to speak at this conference of clinical academic health centers, and we'll follow Professor Gaudio's excellent overview about how academic health centers interact with their communities by providing some specific examples of my institution, which is Eastern Virginia Medical School. Just testing the delay in the clicker here. Are you able to advance the slides for me? For some reason, the clicker is not moving. Okay, thank you. I'll just talk to you. So Eastern Virginia Medical School is, in terms of the United States academic health centers, kind of a mid-sized enterprise. We have an annual budget of about $300 million. We have educational programs in medicine and then 20 different health professions programs. We have graduate programs in 19 specialties, and we have an active research enterprise that tends to focus on cancer, cardiovascular disease, maternal and infant health. So we have big impacts in our community, but one of the things that is distinctive about our institution is that it literally was created some 50 years ago by the efforts of the community who felt like that healthcare in the region was lagging both the state and the nation. And so they created Eastern Virginia Medical School, and we have adopted as our mission to be the most community-oriented school of medicine and health professions in the United States. That's a very broad vision, but I wanted to give you some specific examples of how we try to reach out to our communities. Of course, we do it through our clinical care programs and our education of professionals in training and our research enterprise. But in particular, we have really focused in recent years on community engaged learning and have created several centers within the academic health center to help us move forward. And I want to talk a little bit about those. Our students, whether it's in medicine or public health or being a physician assistant or whatever the program, they're very interested in community service. And we noticed about a decade ago that we had lots of students doing lots of projects in the community, but we didn't really have a structured approach to the educational objectives of this community engagement. And so we've become much more systematic. We probably do hundreds of community activities every year, but we try to make sure that those are done within a context that has specific objectives. And that's what I want to talk about for just a little bit. Next slide, please. So definition of community engagement from the Carnegie Foundation is shown here, and I think it does a really nice overview of what community engagement is. And so it, just to read it, you can see the slide obviously, but community engagement describes collaboration between institutions of higher education and their larger community. What's really important in there is that true community engagement dialogue among the community that you're trying to help and the faculty and students of the academic institutions. Historically, at least in our institution, if you go back 20 or 30 years, our faculty and students would learn about some need in the community and design an approach to meet that need as much as we could with the resources that will, but they really wouldn't engage the community. And so what we found is that we weren't as effective as we wanted to be, and that we needed to do what the Carnegie Foundation has outlined here. We really have to view this engagement not just as us doing something good as a previous speaker talked about in terms of social determinants of health, but doing it in a way that it builds on the needs and wants and culture of the community we're trying to serve. Next slide. So community engaged learning at our institution is described here, and that is that we're looking at meaningful service with structured educational objectives. So, for example, when we run a free clinic where we reach out to several hundred patients who are mostly adults, mostly have chronic hypertension or have diabetes, we set up educational objectives for our students. We want them, for example, in that setting to demonstrate a knowledge of interviewing patients, of taking a history, of looking for other sources of information about the context in which the patient lives. And so we create not only the community service, but very specific educational objectives, and we train our students in that regard. Next slide, please. So I've already covered a little bit of this about understanding the need of our institution is a little different than the major institutions, for example, at Johns Hopkins or Duke or University of Virginia or Stanford, any of the internationally recognized academic health centers, because generally the strength of their research and clinical care. We grew out of the community, and our community needed better educated physicians. They needed more public health students, and so our programs are a little different than those in that we really are focused on developing things that are active in our region of the Commonwealth, which has about 2 million people in the southeast corner of Virginia. Next slide, please. So you're familiar, and the professor covered social determinants of health. The important point, of course, being that we know that healthcare in and of itself is a relatively small contributor in the overall context of the health of the population. And so our community engaged projects, for the most part, aren't clinical, although they do involve some clinical care. They're really more concerned with the other social determinants, the family living situation, the socioeconomics, the behavior patterns. Next slide, please. And that just is the graphic that we've all seen many times that shows the overwhelming impact of the social determinants of health, which means that drives our programming. Next slide. Could you move the slide? Thank you. So this is just an example of what we have done in the past year. Just to give you an idea about community engaged learning, we had about 3,300 hours of community engagement through various programs. We had almost 160,000 medical student hours, that is hours that our students, and we have a class size of 150 students, and at any given time, about half of them are involved in some degree of community engaged learning. And so the students in the aggregate have spent about 160,000 hours in programs. We have, as you can see here, invested in infrastructure to allow us to move supplies around the region, because again, a part of community engagement is that very little of our community service occurs on our campus. Rather, it occurs out in the community, and we've had to invest in the infrastructure to allow us, our faculty and students, to get to the community. Next slide, please. Obviously, all of the programs that we've done in the past year since March of 2020 have been affected by COVID-19. And we've been we never closed our institutions, and our students only missed about 6 weeks of clinical rotations in March and April of last year. But we were very rigorous in implementing masking and social distancing and sanitation. And this picture is just an example of one of the things that we allowed our students to do. As long as they wore a mask, you can see they're not doing as well on the social distancing as we would like, but they were outside. But we had our students delivering supplies, medical supplies, food, informational supplies, so that we continued to engage the community during the past year, using as many means as we could, but we had to do it very differently because we couldn't just send students out in the community. We started sending students back out into the community about 2 months ago as the vaccination program began to roll out, and the virus, at least in the United States, began to moderate. But there's no question that the last year we did much less than we normally do. Next slide, please. So you can see the figures here. I won't go over all of them, but this was in fiscal year 19, which was the year before COVID really impacted us. And you can see again, 100,000 hours of community service. The number of people that we reached was about 50,000 people. We had 3,000 student encounters. We had faculty and staff, 367. A lot of our faculty members, but also our administrative staff, willingly volunteer some of their time to support this community engagement. And as a professor noted in his talk, this requires a shift in mindset of the leadership of the Academic Health Center to make a determination that they think it's appropriate that their large institution as an academic health center reconfigure itself, engage the community, and undertake projects that are seen by the community and by the professional literature as being effective in addressing different aspects of the social determinants of health. That's not all we do. Obviously, we have educational programs where we're students, and we have to make sure that they perform well on national exams to continue to advance. We have substantial laboratory research projects, and we have a large clinical care program. So I'm not suggesting that community engagement is more important than those other traditional missions of an academic health center. Rather, I'm suggesting that one of the things that the health centers can do to increase their impact in the community is to really engage the community in developing programs. Next slide, please. Next slide. It's still populating. There we go. So this just shows you some of the partnerships that are involved in our programs. VDH, that's the state of Virginia Department of Health. Centera Healthcare is our major, we don't own our own teaching hospital, but we're a partner with several. Centera Healthcare is the largest. Old Dominion University is a collegial institution that we cooperate with, a couple from our campus. CHKD is the Children's Hospital, and so we do a lot of work with the health department, with our major healthcare system, both on the adult side and the children's side, and then you can see others. But the point of this is that we're engaged in the community in a way that has us reaching out to lots of different organizations because they have a role to play in addressing the social determinants of health. Next slide, please. So one of the areas that we've had a particular focus is in maternal health. We have one of the higher rates of infant mortality in the Commonwealth of Virginia, which is itself subject to higher rates of infant mortality than the rest of the United States on average. And we found that a lot of that can be that rate can be impacted by community outreach, because a lot of the problems that lead to pregnancies that produce low weight babies or early term babies are social factors. And so we've designed programs to work with parents and family members of mothers to be, and we've had real impact in terms of reducing infant mortality, both in the population at large and then within the particular population of people of color, where the rates tend to be double what the rates are for Caucasians. Next slide, please. So these are just some examples of programs that we engage. So we run free clinics, as I said, that tend to be in the evening, where we have faculty overseeing students, providing basic primary care to patients who otherwise have no access to care. We're very concerned about early childhood development and making sure that children under the age of 6 do in fact have adequate nutrition and have adequate engagement socially and intellectually. And so we have a variety of programs, again, that work with the community to try to have a positive impact on them. Next slide, please. One of the particular foci, and I'll mention in a minute, we created the Brock Institute as a center within the Academic Health Center to be one of the places that leads community engagement. And they've really focused in the last 2 years on mental health, which is a real problem for a number of our populations that don't have a lot of resources. And of course, everybody has been affected in the last 18 months by COVID and the isolation of having to stay home and quarantine for long periods of time. And so one of the things that we've done is work with community agencies of all sorts to try to help people understand mental health issues and make referrals as appropriate. And the main point I think I want to make in terms of this conference is there is no set menu of community engagement that every academic health center ought to undertake. Rather, in my view, they need to engage in a dialogue with the community. They need to look at vital statistics. They need to talk to the clinicians. They need to talk to the public health outreach workers. They need to talk to the school teachers. They need to reach out into the network as broadly as they can to try to understand what the real issues are and what the opportunities are to have an impact. Next slide, please. One of the things that is one of our newest initiatives is we've created a Center for Maternal and Child Health Equity. And you can see there that we can't solve all the problems in our region. We know that. That's not what we're trying to do. What we're trying to do is create a sustained focal point and provide professional expertise and student volunteer hours to do the best that we can with the resources that we have. And so in general, our foci within the institution have been focused on maternal and child health, on pediatric health in and of itself, in trying to educate students about good health and nutrition and provide them appropriate social interactions, really trying to engage them in every aspect. That's in addition, the focus on maternal and child health is in addition to our ongoing focus in various types of cancer and prevention programs where we can help people monitor their health and hopefully avoid a serious progression in cancer. And then we're also focused on diabetes, particularly type 2 diabetes, because it affects such a large percentage of the program. But I think I will conclude here by saying in a very quick overview, and you can go to our website at Eastern Virginia Medical School and click on community engagement and get a wealth of information about our programs. I think the most important points parallel those of the professors speaking before me, that we have to be purposeful, we have to be inclusive, we have to have metrics that tell us how we're doing, we have to be willing to change, we have to understand that community engagement is in fact in 2021 a critical part of our responsibilities to our surrounding communities. So again, I appreciate the opportunity to speak at this conference on clinical academic health centers in Europe, and I look forward to our conversation. Thank you very much.
Thank you, Professor Combs, for the very interesting talk. And we are going to move to the last speaker in this morning session, Dr. Andrés Reis, Director of Health Systems, Medical Products and Innovation of DG Santé, who is going to talk about capacitating clinical academic centers to achieve high-level scientific, clinical and societal impact in the European and worldwide context. Please, Dr. Reis, the stage is yours. And I just would like to remind speakers to keep the time so that we can have some time for a couple of questions at the end of the session. Please, Professor Reis.
Thank you very much. Thank you very much, Chairman. I don't have a presentation. I will try to use a shorter time for my reflection with you. Let me start from a confession that I used to be also academic. I used to work in clinical center at Krakow University as radiologist. I also was the founder and director of School of Public Health at my university in Krakow. And I have also a chance to be in Virginia in my residency, part of my residency program in Roanoke. So very happy to hear from Professor Combs about the development in his center. When we see the today's picture in Europe, of course, it's difficult not to see Europe and the global world from the experience of COVID-19 pandemic. It's continue, but at the same time, it shows, how vital is and important is health for society and also for economic development and prosperity. So I think this is very clearly also show, how important is cooperation in science, in clinical development, taking care of the patients, looking for the best options of treatment and prevention. So we learn a lot. We also learn how difficult is this area and how unpredictable is this small virus, which is crossing the borders without control, without passports, since already more than a year. We are tired. We are in short-term focus on winning this fight with the COVID-19, but I think in the long term, we as policymakers, as academic, we should look for the bigger picture. How we protecting our citizens from the common health threats, and I think there were a number of already comments around the prioritization of our efforts and developments and talents we need and programs we have to develop. It's also about future of European Union. Those slides, showed by Professor Hagen about European continent is showing, that we are quite important in the world, at least in the lights. But at the same time, we have to think about the way we are integrating and interacting with the rest of the world, but also across borders of European Union. So this pandemic also put the spotlight on the health system, and also we understand better, how we have to build the effective and accessible system. But at the same time, we understood better there is an issue around resilience of health systems, how we should train our workforces in the adequate numbers. This, I think, is reflection which we will have and we have to have in coming months, because we know that borders in Europe are open. Graduates of medical school, nursing school, other professions can travel without specific requirements for additional documents. Just need to have graduation and meet the right language requirements of the country of activities. We also understood better, about the way innovation can be employed for the society. I think in the experience from Leiden University, we have seen the vaccines was somehow the concept of the patent was developed there. Then we have all developments around Ebola vaccines, and then we came with a situation when the call came from all of us to have vaccines as quick as possible, and scientists and industry, and finally also public payers and regulators were all able to first work together and also to respond to this challenge. Europe was able to purchase vaccines, and now we are able to deliver them to our citizens. Hopefully it will help to find the final end of this pandemic. But also we're challenged by education and the needs for the retraining. The example is the needs for ICU personnel. As a European Commission, we're able to dedicate additional funds during last summer to help European Society of Intensive Medicines to prepare the program, which many of your hospitals, clinical centers participated to retrain doctors, nurses to work in ICU settings in the needs we were facing. But I would like to use the one example which I think is close to many of you, and I think is also showing how important is European cooperation. The case study is about European reference networks. This is one of the flagship initiatives. This was born many years ago as a concept. Later was regulated by this directive, which was dedicated for patients' right for cross-border healthcare. And the work, the setting up process and organizing, it took us last 10 years. But I think we have to be proud what we achieve, together as clinical centers, as the European Commission, as member states, because what's happened in this area, that we were able to find a system which is helping patients to get access to best possible knowledge to the 24 networks of specialized in the rare diseases. Today, they have almost 1,000 centers. In next few months, most probably will reach up to 2,000. So it's also very vital project with a lot of new type of challenges and expertise we are learning. And but the most important, we help knowledge travel. Not need for patients to travel is important. That knowledge travel, we can learn together. We can have the panels between different centers, which are able to provide expertise and solutions to the patients, but also working together on clinical guidelines or on clinical trials. We're able to develop new ideas, new therapies, look for the solution. This also is a community of patients. Very close cooperation with patients organization, already mentioned by Professor Hagendorf. I think this is a great example how important is involvement of patients. And in the area of rare diseases, we know how difficult it is to define those diseases, but to live with them. and to get, of course, right treatment is even more difficult. So cooperation, understanding better patients' needs, but also working closely with clinicians, with clinical developments, including, of course, development of new medicines or medical devices is a critical factor. We're able to dedicate additional funds, helping, in one hand, working across continent. Secondly, establish the IT platform which allowed us to communicate and, for example, establish this multinational panels to give the advice to the clinician, who is in charge of individual patients. But also, we are able now to add the additional layers like e-learning system or exchange program for professionals. Hopefully, when COVID is less harmful, we'll be able to move from country to country and get quite specialized short programs to support each other. Other layer of cooperation is cooperation between CEOs of hospitals, and many of you are participating in this program. And there's also a place when managers can exchange experience and can help networks work better. But what I found interesting during meetings, in Rotterdam, in Paris, that there is also lack of knowledge about and experience about the way academic centers are working. So in the last meeting, it was unfortunately already quite long ago because of COVID situation. We understood that there is a need for joint research about your institutions, and I think this was also mentioned by Professor Gaudio that we need more knowledge, because we have the knowledge which is coming mainly from the US and still missing this type of knowledge from Europe. So ERN is also about research. I mean, we also were able, together with member states, dedicate special program to support research. And of course, European reference networks, as networks, they are much better equipped to push and to develop, good projects that can be supported by this program. And the last point, which I would like to mention, this is linked to on the European Reference Network, is links to the concept of European health data space. Again, this was mentioned. Data is a big coming challenge to all of us. And European Reference Networks already are able to build joint registers and create the power of data because of the quality and control kind of data sets, which hopefully will help with R&D and clinical assessments and so on. So as a continuum, we plan to propose as European Commission by beginning of next year, so-called regulation on European health data space. This is a very important one because it's also going to help researchers and clinicians to bridge data across continents and develop better quality programs and research projects. Let's move to the next area, which I think is very challenging, already mentioned by the speakers, digitalization. More than 2 years ago, 12th of April 2019, we had, I think, very important meeting. Some of you participated in this meeting when the deans of medical schools discussed about the challenges coming with digitalization in education, in research. And this declaration, or the concept we developed together, I think is still valid. And I would like very much welcome your work and activities in this field. As a commission, 16th of February, we organized a roundtable with stakeholders to identify the needs and opportunities to reskill and upskill the health workforces. The role of academia is a critical for undergraduate and, of course, postgraduate education. So we hope you, academia, will work together with us, with private sector, with Ministry of Education, Ministry of Science, Ministry of Health, and also professional associations to build the partnerships in this topic. I hope we will continue this development in next months and years. I think that this declaration, I think, is a really good starting point. We also know that Erasmus Medical Center is now running the network, which is kind of warming up. We offer the platform of European Commission to be used to network academia and work on this field. So I will also stress the needs of talents and needs also education, multi-sectoral education is a critical one already discussed. And I think the need for data scientists and also, you know, the understanding better, you know, how we can use data is a big challenge. And I hope you will have time discuss, you know, how education system can respond and create, you know, better not just number of specialists, because I think this is already important, but also quality, which can be employed in life science sector and across Europe. And let me finish with the two last points. One is about regulation. Of course, European Union is also about regulation. A number of our regulations are also important for your work, for global community as well. Just mentioned the one on data protection, which is quite challenging, is in one hand very much welcomed by citizens, by those they would like to protect our data, and I think many of us challenged by this as well. At the same time, of course, it's creating a lot of demand for handling data and keep them under individual control. So we are trying to address those issues, I know, and this is current joint actions chaired by Finland to help and work across continent on the implementation of different sets of data requirement, data regulations, and hopefully also it will help us to create better regulation for European health data space. The other important part of our work is pharmaceutical and medical devices regulations. So medical devices regulation will be in place in next week, 26th of May. We are starting new era in Europe with a new regulation in this field. A lot of challenges ahead of us and industry, but we believe it's a very good set of rules basically required for the modern technologies, but also modern healthcare. And the last one I would like to mention is this pharmaceutical strategy for Europe, which was published by European Commission end of last year. There are a number of activities there. Are very welcome if you can have a look on this important document, which is also important for your work. One area which I would like to highlight is implementation of clinical trials regulation, which finally will be possible from 31st of January next year, when the portal hosted by European Medicine Agency will allow better cooperation across medical centers, clinics, in set up the clinical trials, and both for academia and industry. And last few words about resources for those activities already discussed today. In one hand, the quite important money allocated to the research program in cancer. They will be also supported by policy program, which is called Europe Beating Cancer Plan. With additional money, we'll be able to dedicate from EU for Health program. This is important program which was finally agreed by European Council and European Parliament, allowing allocation of 5 billion euros, you know, to this program, which is quite important decision, because in numbers It is more than 10 times more than previous health programs run before this year. It also shows how Europe is trying to support this work in health and health policy area in coming years. And finally, we are now in the important moment when member states are finalizing the work on Recovery Resilience Facility program. This program is almost 700 billion euro program, which is helping member states, European Union to prepare, respond after COVID in many areas. But of course, one of the areas which we see member states are addressing is also life science, research, healthcare, digitalization. And I think that it's also important that academia, medical centers, academic centers are participating or will be participating in this program. So thank you very much for this opportunity to speak to you today, and happy to continue discussion. Thank you.
Thank you very much, Professor Rees, for your interesting overview, highlighting the power of cooperation. And we have a couple of minutes for a couple of questions. As we are having some problems with the questions from remote audience, I will ask the people present in the room to ask questions. Just one question, please. Luis, yes.
Thank you very much. Thank you very much for this opportunity. I think this was a very interesting morning. I would have two questions, but I will bring two questions.
Please,
Is that all right?
go on.
Thank you very much. Well, my first question is for Professor Pancras Hogendoorn. And, well, thank you very much for a very elucidating talk. Now, you mentioned about threats and opportunities in terms of clinical academic centers. I would put to you that your experience is, of course, conditioned by the Dutch experience. I also worked in the Netherlands for a while in Amsterdam, and I know it's a fascinating approach to having a clinical academic center because it's an integrated model. Now, the problem that arises in other countries is that we don't have the adequate legal framework to have an integrated approach, and so you have to have parallel institutions working, well, I would say trying to tag along or to have joint objectives, but that can also definitely change the threats and opportunities. So my questions would be, first, how did you reach the conclusion that you really would have to have an integrated approach to clinical academic centers in terms of the governing board, so that the strategic approach would be a single one? And the second one is, in case you no longer could do that, what would you conceptualize as the main threats to having as impactful clinical academic centers when you can't have the integrated approach? Now, I would also like to ask Professor Combs, and I would like to congratulate you on your approach, community-focused one. It's very, very interesting. What actually didn't come across quite clearly to me was how you liaise with local hospitals and the primary healthcare centers, since if you really want to have a single approach, or I would say structured approach to community-based problems, it is very important that everybody works together and that there is an alignment of strategies. So that was something that didn't come across to me, because you were speaking, I would say, on behalf of the medical school. So in the broader context of the health care in Eastern Virginia, how do you liaise with those academic primary healthcare centers and the local hospitals for a joint approach? Thank you very much.
So shall I?
Yes,
first?
please, Professor Hogendoorn.
So there is some echo. You're hearing me correctly? correctly?
Yeah.
So the happy news is that both Portugal and the Netherlands are under the same European law. So what has been done in the Netherlands, I think theoretically could be done in Portugal as well with regard to the governing board. The way we did it when it all started is just starting to put two boards together in one room and act as one board, while it was not legally arranged yet. And during the course of time, we changed the formal position and also changed this in the law. So when Portugal would be interested, it would be easy just to show the legal framework in which we are operating, which means that two ministries, with the Ministry of Science and Education, one hand, and the other one of the Ministry of Health, team up to make these kind of things possible. But again, it all started by just combining the board of the hospital and the medical faculty into one board, and you don't need a law for that. It's just the willingness of both organizations.
Yes, we agree with you, but it is surely a very difficult task for us in the country. So the other question, Luis, was to Professor Combs. Professor Combs,
yes,
please.
thank you. So I think I have to answer the question in saying that the liaison with our partners occurs at multiple levels. At the highest level, we have what you might call a policy board of individuals who represent the faculty, who represent administration within the academic health center, but who also represent leadership positions in our teaching hospitals and in our community faculty and with the health department, as well as community leaders who could be ministers within different churches that are important in target areas, or local political leader, mix of all of that. So at the highest level, there's a discussion which is to help to identify what are the most pressing problems that we can help address, either because they're newly emergent problems or because they're under-resourced. And once we pick a target, then we reach out to the appropriate community partners to develop projects. And the projects are done at a more operational level. Not everybody's on every project team because they don't have the expertise required. But we have just continual communication at a regular level, at the policy level, at the high level, where we're identifying problems and opportunities and general strategies, and then at the project level, where we have specific people who have resources, talents, knowledge, and so on that can help address the problem. So it's both at a policy level and an operational level, and we meet all the time. I hope that is responsive.
So thank you very much. I don't know if anyone wants to ask any question. I have a question for the three speakers, if you want. We, at least in our country, translational science and translational research is, there is a gap in this kind of research. And I'd like to have your thoughts, or to if you are kind enough to share your thoughts about the role of clinical academic centers in the dynamics and in the success of this translational research. Can you comment, please?
Well, I try to explain that in order to be successful, you have to draft a pipeline from fundamental research via collaboration with industry and to academic health centers where the first in man, or when you want first in patient application, is done. And it's easy when you have a academic health center which harbors the medical faculty and the fundamental research there as well. Or it's not easy, it's easier. And when you have a science park around you with companies, then it's also easier. But I think the end point one should envision is to have that setup all together, and when it's not there yet, to actively draft the pipeline from fundamental research into collaboration with industry, into application of new findings and for instance new drugs in patient in academic healthcare centers. So when it's not in a natural way together, as lucky we are here in the Netherlands, then you have to do some efforts to draft it together as a way of organizing and a way of discussing things. It will not go by itself, that's for sure.
If I may add from my experience, from both academia and commission, from my academic experience, when I ran the Center for Innovation and Technology Transfer, I remember the one of the critical problem was the understanding of intellectual property rights operation in the universities. We have to be very careful, how we put the system in place that we don't paralyze basically the academic, to deliver as many good ideas as possible. But at the same time, we have to protect, the IP. So but this is right balance, and also, how this can be transferred to the industry partners is the next important problem. So we need kind of brokers, to help understand better, and such centers like mine was, I think, a good idea. I continue to work quite effectively at my university. The second, I think, is open door. I think already mentioned by Berso Hagendorn to the startup communities. I mean, today, and I know from Portugal's experience also that there are many companies, especially in this new type of research like digital. We see that ideas are coming from engineers, from IT, from many people. They never have been in health as such, but they really need clinicians as the partners. But of course, we need to find a way how they can get into relations that we don't build too many barriers. And this is sometimes brilliant and talented, people simply they don't know how to get into relations, and they are paralyzed by the system. And the last point is from my experience from European Commission. I am also the member of the board of Innovative Medicine Initiative, which is the important public-private partnership, by the way, based on the experience from Netherlands. It was established more than 12 years ago, and we brought, interaction between. It was established together with the industry. So the budget is half EU budget and commitments from industry partners. And this is also a way to work. And I think this model can be also built nationally, I think, as a Dutch example showed. And this in this new programming period, we are moving to the new type of public-private partnership based on the experience from IMI, which is called Innovative Health Innovation Initiatives. And this one will bring not only pharma sector, but also medical devices and digital sector. So I think the way your universities can join the effort, I think also will help you to kind of train the best models. So very much welcome to follow this development, and please participate. It's a very open call.
Professor Rees.
Just very briefly, just a couple of comments. One of the things that we've found in cooperating both with industry and with our healthcare partners, teaching hospitals and community physicians, is we needed to spend some time creating a structure to sustain a conversation to achieve the objectives, because we have multiple people who own the data, and we have to have agreements in place that allow us to seamlessly share that data with the appropriate permissions if we decide we want to focus on a new drug for diabetes or a new treatment path for cardiac disease. We have to have the mechanism in place to facilitate collaboration. You don't want to have to negotiate the terms of transfer every single time. And so my point is, if you decide you really want to move in the area of translational research, the data to support that comes from multiple sources, and you need to spend time establishing the mechanisms that allow the transfer of that data.
So thank you once again. I don't know if anyone wants to ask any question. So if there is no more questions, I'd like to thank the speakers for sharing your experience and your thoughts about the future perspectives for the role of clinical academic centers in promoting research and innovation, and really opening new ways to improve citizens' health care. And I'd like to thank the audience for the discussion also. Thank you very much. Thank you once again.
Thank you.
Thank you very much. Bye-bye.
Thank you all for this fruitful discussion. We have been experiencing problems with the YouTube chat, but we hope to overcome the issue in the afternoon period. The session will now be interrupted for lunch. The conference will continue at 2:30 p.m. with the second roundtable dedicated to the theme Improving Partnerships and Networking Among Clinical Academic Centers. During the afternoon, you can continue to attend the conference on the same link. Thank you.